Soundbytes. Quick clips, long-term learning.
Okay, last case we have is actually a young woman, 18 years old, who came in, had a history of pericarditis in the past, and it's coming in today with chest pain and shortness of breath. So they're doing an echo here. We've already gone through some of the echo findings on a previous case. So can you break down this pericardial long axis view, what you're seeing?
Yeah, I'm seeing a pretty significant pericardial effusion, and the way I know it's pericardial is because it's kind of like circumferential and passing like above the descending aorta.
Right. So we see the descending thoracic aorta right here, the effusion here splitting between the myocardium and the descending thoracic aorta, and it is circumferential. What about the ejection fraction and the overall LV function based on if you did like an EPSS for her? What would you expect?
Yeah, actually probably normal. The mitral valve looks like it's moving and slapping that other wall pretty significantly, so probably normal, which would give us a false illusion that the patient's okay.
Yeah, because we'll see that she's probably not okay. She's developing something potentially concerning. So in this, what do you think about the LV cavity itself? It looks fairly small to me.
Yeah, it's kind of, the walls are kind of touching each other.
Yeah, so it's probably suggests that the LV is like kind of underfilled, which can be one of the problems when you develop tamponade physiology, which is what we're going to get into for this case. So looking at the peristernal long, what are some other findings of tamponade? Well, first off, clinically, what was a kind of classic teaching for tamponade?
Yeah, so the triad of symptoms signs would be distant heart sounds, hypotension, and JVD.
Right.
And then another
It's
thing.
called a Beck's triad.
Yeah.
But kind of hard to ascertain in the ER sometimes, distant heart sounds and everything like that.
Yeah.
So sonographically, though, what are some changes that we can see when you'd be concerned for tamponade?
Yeah, so you can see like right ventricle collapse, which would be kind of like paradoxical because normally we want the right ventricle to be filled during diastole, but due to this fluid around the right ventricle, it's actually decreasing in size.
Right. Yeah, so RV diastolic collapse is one of the big findings because during diastole, when the mitral valve and the tricuspid valve are open, the ventricle should be getting bigger. But when you have collapse of the RV, because the RV and the RA are more susceptible to those external pressure changes due to just being a lower pressure system than the left side of the heart, you see some collapse and hemodynamic change. So let's go over to the peristernal short axis now. We notice that there's the similar underfilling of the left ventricle. No obvious like wall motion abnormalities, but again, we see that circumferential effusion here, anterior and posterior to the heart. But what do you notice about the RV here?
Yeah, it's small, and it's also getting smaller when it shouldn't be, right?
Yeah, specifically in this area, you see this bouncing movement of this RV, that you get concerned about pressure-related changes and collapse of the RV there. Sometimes people call it as a trampoline sign. Looks like a little person kind of jumping on a trampoline right here. Now we have subcostal view. What do you think about this image?
So it's not really a great image. I don't know if I can point out anything in particular.
Yeah, I'd probably just say this is kind of a non-diagnostic image, and maybe hard because she's short of breath or uncomfortable or whatever, but you can't really see the heart that well, so I wouldn't really make any decisions based on this. So one thing that you can do is try to have them take a deep breath, and we'll bring the heart closer to your probe, but she may not have been able to do that in this case. So we'll just use our other views. Like the apical 4, as we discussed earlier, we have the left ventricle on the right side of the screen with the left atrium deep to that. And then here we have the right side of the heart. And then we see some of that pressure-related change as well. You see the kind of the RV wall bouncing a little bit in. That's concerning for a tamponade physiology. Lastly, if you're not sure what phase of the cardiac cycle you're in, right, because we said that there should be RV diastolic collapse, you can use M mode. So we did this earlier with EPSS, and they're basically doing an EPSS, but we're also looking at the timing of the opening of the mitral valve and looking at the relationship between that and the RV free wall. So here, as we did before, we have the EPSS tracing, the E wave and the A wave here. So ejection fraction wise, they're touching the septum, so that's normal. But then if we look at the RV wall here, what do you notice? As the pattern, as diastole starting here, you see that there's actually the RV is coming going away from your probe, which means it's dipping inward and collapsing a little bit. So this finding is concerning for tamponade. In this case, they didn't include an IVC, but if you were to include an IVC exam for this patient, what would you expect?
Yeah, pretty enlarged because all the blood is unable to drain into the right atrium.
How much fluid needs to accumulate before you develop pericardial tamponade?
Is it more about the rate of the accumulation of fluid versus the actual amount?
Right. Yeah. So some patients, that where it's accumulated really slowly due to cancer or renal disease, whatever, sometimes they can have a massive amount in their pericardial sac without developing any hemodynamic change. But when it develops really acutely, like I suspect in this case, even small or moderate amounts of fluid can cause pericardial tamponade pretty quickly because the heart doesn't have time to accommodate to that change.
Soundbytes. Quick clips, long-term learning. This soundbite is a shorter, digestible segment taken from our monthly Soundcheck podcast. For the full episode, check out the podcast on YouTube at youtube.com/MedStar Emergency Physicians or visit mepsono.com.